Good morning. Today, let's talk about endocrine emergencies. Thank you for joining me. About 65 slides, should be fairly fast, a little more than 30 minutes, a little less than an hour. So here we go. Endocrine emergencies. There we go. As long as it works. So today we're going to be able to define hypoglycemia. Yes, there's going to be a trend today. State signs and symptoms of hypoglycemia. We're going to identify treatment for hypoglycemia, and we're going to define hyperglycemia, what the symptoms might be of that, and then how we can treat that. So let's start with altered mental status. When you see my slides, you may see this slide very often because Charlie Sheen is definitely in an altered state. So here we go. Let's talk about some altered mental status. The most common killers, but very common causes also, are stroke, seizures, infections, sepsis being mainly, which people tend to, if you don't recognize the signs, can progress down that path very quickly. Meningitis, encephalitis also. Hypoglycemia, very common, very easy to fix and reverse if you recognize it. In toxicology, your toxidromes, drugs, alcohol ingestion. So alcohol and opiates are very, very prominent in our world right now. So let's do a little review and talk about the anatomy and physiology of the endocrine system. Okay. So the endocrine system it's a message system of your body. It controls different functions in the body, and it maintains that homeostasis. Homeostasis is kind of a definition of balance. Where does your body want to live in the balance of things? So, question: what part of the endocrine system secretes hormones? Glands. So your glands will do that. You know, notice the gland, the adrenal, the thymus, the thyroid, the testes, the ovaries, the pancreas. All right. What are the hormones? What are those hormones? If you think about those, they're chemical messengers. They're the little Paul Revere's on his final ride. But they're chemical messengers that regulate other organs and tissues. Okay. The pituitary gland. What is the main purpose of the pituitary gland? That is the master gland. It controls functions of the other glands. So it's the head honcho, it's the foreman. It oversees what the other glands are doing in the body. The thyroid, what's the purpose of the thyroid? That influences the rate of metabolism. So if you have somebody with hyperthyroid or hypothyroid, think of what that might mean. So hypothyroid, you have a lot of weight loss, loss of energy, that kind of stuff. But on the hyper side, you can have somebody that can't gain weight or tachycardia and the things that might go along with that. The adrenal gland, the purpose of that is the fight or flight response. So it controls the stimulation for the sympathetic nervous system. And the main purpose of the pancreas, this is where we really start getting into stuff we can treat. So this regulates the blood sugar by production of glucagon and insulin. And they also have digestive enzymes that are coming from there. So now let's talk about the big one, diabetes. Diabetes. This is something that is very common, and a lot of people with diabetes, especially when it's uncontrolled, lead to all the other medical problems, the heart disease and strokes and obesity, and the list goes on. The list goes on. So, but the pathophysiology of it, it's a metabolic disorder. It's an impaired ability to produce or respond to insulin, depending on if it's type 1 or type 2. And it can't metabolize simple carbohydrates such as glucose for fuel. And then there's a difficulty of the system to regulate sugar levels. So diabetes insipidus, this is excessive urination that comes with this. Diabetes mellitus is the sweet diabetes, you may hear it called. And then you have type 1 and type 2, and they're both equally serious. They both affect many tissues and functions, and they require lifelong management. Lifelong management. Let's talk about type 1 diabetes. This is where the body does not produce insulin for one reason or another. The pancreas is not producing that anymore. These people that have type 1 diabetes will need daily injections of insulin. Usually this onset of this is during childhood, and they're likely have metabolic problems and organ damage. More likely to have that, especially if they're unmanaged or they're poorly managed, which we run into. A lot of people don't educate themselves very well to their own medical problems. Type 1 diabetics are usually significantly better educated about it than type 2 diabetics, because type 2 is usually an adult onset. Type 1, they've lived with it for their lives. So you have very good athletes and people leading normal lives with this type 1 routine that they have to deal with daily. This is considered an autoimmune system. So this is the immune system is attacking its own body, basically. So a diabetic's immune system is too busy attacking its own body to protect you against every illness known to man. That's kind of a broad statement, but kind of true. So type 2 diabetes, this is where your body produces an inadequate amount of insulin, or insulin does not work efficiently. So when you might hear patients that lose the sensitivity to insulin. So some require insulin, some require oral medication, some are also controlled by diet. Medications stimulate the pancreas to produce more insulin. Some are controlled by diet and exercise, as I said, and this also often states later in life. This is more common than type 1. This is actually a very common onset of people that struggle with obesity. You'll see a lot of type 2 diabetes. So treatment for that, the injections of insulin or oral medications, kind of chit-chatted about that. But what is the role of glucose and insulin? So all of our cells need glucose. The brain is the greediest organ we have in our body, for obvious reasons. Without our brain, we're going to die. That controls so much in our body. So it's going to take whatever it can get. But so the brain is acutely sensitive to diminished levels. So if you think about that, what do you think might be the first sign of low blood sugar? And that is probably their mentation, because that's coming from up here in the grape up in the head. There you go. So insulin, it acts as a key. It allows sugar to pass from the bloodstream into the cells. So if you have the diabetics, when they're initially diagnosed with diabetes, type 2 diabetes, they're found, or actually both diabetes, their blood sugar levels are very high, and then they have to investigate further. Is it insulin production or lack of utilization of the insulin in the body? So we need to identify that, because if there's the insulin isn't there for the blood sugar to ride with or get into the cell with, it's not going to work, and the sugar will just stay in the bloodstream. So insulin, being the hormone that it is produced in our pancreas. It allows glucose and sugar to enter the nourished cells. You'll find that glucose that we talked about is transported by that bloodstream. There you go. In a normal day, remember we briefly said the word homeostasis, the balance. So on a good day, you have the balance of good insulin and good sugar. It's doing what it should be. So when we start to deal with hypoglycemia, we have insufficient glucose in the blood. Could be for many, many different reasons, which equals insufficient glucose to the brain. This is a life-threatening emergency. This is easily treatable when it happens. You may also hear this referred to as insulin shock. So, in a graphic, kind of looking at it, if you look at not enough sugar because there's too much insulin. Things that might cause that are the patient took too much insulin, the patient hasn't eaten, the patient over-exercised or overexerted, or maybe they've been vomiting after eating, especially if they've taken oral medication. And then they took insulin. So if they don't have the intake of carbohydrates and sugar, they could potentially go very low if they still have taken their insulin. You'll run into diabetics, especially the ones that are poorly educated or do not take care of themselves, that will take their insulin because their doctor told them to, but they don't test their sugar. So they'll either be really high or really low because they don't monitor it. So that's where people will get themselves in trouble. Or they'll take too much insulin because perhaps they weren't paying attention or they don't remember taking it in the first place, so on and so forth. But the signs and symptoms of hypoglycemia, hey, there's Charlie again, it's usually a fast onset. Somebody might feel like, oh man, I feel like my sugar is low. You'll hear somebody say that, usually because they know what it feels like. So after taking insulin or missing a meal, common denominator of when the onset is happening, and after taking insulin and vomiting, they still don't have any intake in their body. After unusual amount of exercise, and for unknown reasons, we don't need a reason sometimes to suspect insulin or suspect hypoglycemia. It just might be the way it is. But it's our job to identify it. So what do we look at? Maybe an intoxicated appearance, maybe an altered mental status. Keep in mind, when you have somebody with an altered mental status and you go to take care of them, don't jump to conclusions. Use your tools you have of assessment and find out potentially why are they in the state they are in, so we could treat it and identify it and treat it. So this is a good indicator. And there's so many things. If you see somebody has cool, clammy skin, or they're diaphoretic, and especially if they're profusely diaphoretic, you pay attention. Your alert should be going off. Exclamation marks everywhere. Why is this patient looking this way? Because when somebody is sick, they become very diaphoretic because it could be they're hypoglycemic, but their blood pressure could be low. A number of things. This is a good clue that you may need to find more information quickly. All right. But somebody might also have just intense hunger. Intense hunger is like, I'm going to eat everything I got to eat right now. I better eat or I'm going to be in trouble. Their body's going to try to compensate. They're going to be tachycardic. They're going to circulate more blood for whatever sugar is left in the blood. They're going to be anxious. They may have a headache. They may be irritated or angry or combative. And then it could be shaky, could be staggering. Then we're like, oh, it must be intox because here we are in the street. Don't jump to conclusions. Hypoglycemic seizure. If somebody is seizing, always check the sugar. Because if they're hypoglycemic that's causing their seizure, if we don't fix the sugar problem, we don't fix the seizure problem. So that is, if they're seizing because of this, they're to the point where there is a true threat to their life. And we need to address that and identify it early and treat it aggressively. If you have somebody seizing, you're going to be kind of handicapped a little because you can't put anything in their mouth when they're doing that because they're not alert enough to take it. That's where I'm like, hey, we need help here, or we need to get this person to the hospital so we can get them addressed quickly. So pediatric hypoglycemia. This is these kids are going to be type 1 diabetics. So remember, they're going to have decreased insulin production. So, but this can cause cerebral edema, so swelling in the brain. This is usually in pediatric diabetics. This is usually the number one cause of death in the pediatric diabetics. All right, let's talk about hyperglycemia. So now we're going to the other end of the spectrum. Not enough insulin is in the body because it's not being produced. The sugar is just cruising around in the bloodstream, which leads to all sorts of problems. And the body is going to try to balance itself. So that's why I said decreased insulin supply. The glucose just rides around, can't get into the blood cells. The body attempts to overcoming the lack of sugar by metabolizing fat. So you'll hear somebody on that keto diet. That's what they're trying to do, is burn fat instead of carbohydrates for energy in their body. But it's a very inefficient way to produce energy. Produces ketones and fatty acids in the blood. This can actually lead to, major problems down the line. So then you'll hear it called diabetic coma. Sometimes you may hear that, but just remember, when the sugar is high, that might not be such a good thing for the patient. So again, this is something we need to identify. We do that by checking the sugar. So remember, this is not enough insulin. There's too much sugar. It needs to be addressed. So causes: undiagnosed or untreated diabetes. This is maybe treated, but the patient is non-compliant with the treatments. Patient doesn't take his insulin. Might have an infection underlying, which goes back to the undiagnosed, but it could be an infection that's causing this. So that's why if you're working on the ambulance, especially if you're working with a paramedic and the paramedic starts an IV, almost all of those patients are going to get a blood glucose drawn, because you never know what you're going to find. A lot of the patients that I say, oh, they should be fine, end up being hyperglycemic. And it's something to add into the list of information that you pass on so they could test for it and prevent future problems. So causes: patient overate. Yeah, Yeah, it's Thanksgiving. We had pies and cakes, and oh, it was so good. So they overate. Their body couldn't compensate for the extra sugars in carbohydrates in the body. So uh, when we talk about glucose levels, we talk about why do we need to test those and how to test them. Remember, we have a glucometer. We have to get a finger stick. If you're doing that way, you get a little bit of blood. The glucometer tells you the blood glucose level by milligrams of mercury when they do that, or I'm sorry, milligrams of per deciliter. So it's normal is 80 to 120, give or take, give or take. So 200 milligrams per deciliter is excess glucose has started to be secreted by the kidneys. So if it's secreted by the kidneys, where's it going? Well, they're urinating it. It's coming out. It's coming out in the urine. So ketones in the urine, you'll hear that. These patients may require large amounts of water to get through this, and then which results in polyuria, polydipsia, and polyphagia. You're like, what the heck are those polys? Well, you know what? Polyuria is the abnormal production of volumes, large volumes of urine. And this is the body's way of trying to get rid of this glucose, of the body's trying to balance itself. Polydipsia, huge, great thirst. They're going to drink, 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 drink. And then, or polyphagia is an insatiable hunger. So depending on which way on the spectrum, is it going to be high or low, depending on what you're going to deal with. Signs and symptoms of hyperglycemia. Oh, that slide could be better. I'll have to fix that. So gradual onset of symptoms. This is hyperglycemia. So remember, that's more gradual. This could be usually over several days. Then you have different things you'll have with high blood sugar is small respirations. You're going to have a person is literally trying to all that they're in a metabolic acidosis. So what their body does is small respirations, which is deep, rapid breathing. Deep, rapid breathing. This is very common in uncontrolled diabetes. So, and then somebody that's in diabetic ketoacidosis. So, and the body, the human body is an amazing thing, and the things it tries to do to keep everything in balance. And the respiratory system is our major drive to maintain the balance, the acid and the base, the balance between the two of them. So what the body does is blow off the excess acids. All right. So you're going to have a acetone, a sickly sweet, just it literally is when you say sickly and sweet together, it is an acetone. It is a horrible smell. Breath, bad smell and breath. It is something that you will smell when you walk into a room and you're like, that's hyperglycemia. They are probably in DKA or almost there. And then you're going to start to have problems with the mentation. So maybe drowsy, maybe confused. It's kind of the same spectrum. So always, that's why it's so important that we always look back to the glucose level when somebody has altered mental status, because that's one big not normal, that could be one big cause that is happening inside the body that isn't happening by an external source, being like a toxidrome or such. Nausea, vomiting, very common in these patients. When their sugar's high, they do not feel well. They do not feel well. So they're going to be nauseous, and their body is going to be rejecting. But then you deal with a hyperosmolar, hypoglycemic, non-ketogenic acidosis. That's a mouthful, right? So this is more common in type 2 diabetes. Body produces some insulin, and then fats are not used for the energy source. You're not going to have that sweet odor of the breath. You're not going to have the small respirations. Um, and then you're going to, the glucose is often extremely high, which is you'll have excessive urination, which leads to very, very profound dehydration. So, and our main goal in pre-hospital medicine is to identify these things early so we can identify the cause and potentially treat the cause. If we can't treat the cause, we need to take our patients somewhere where they can treat the cause. If you hear howling in the background, that's our foster dog again. Upstairs, I don't know, must be getting excited for a treat, who knows? So what is the role of glucose and insulin? The role of glucose and insulin. Here's a good example, finger stick. You have a glucose strip, put it into the machine, it turns it on and activates it. And then you get a drop of blood on the finger, you dab the blood to the end of the glucose strip, it will give you a number. You will definitely see this moving forward in your with the agencies you're in. Keep in mind, though we talk about this on a BLS curriculum, this is still something that is agency specific, approved by that agency's medical director. So there'll be specific training that you'll do with the agency, mainly to be familiarized with the glucometry equipment that they're using at that agency. So, but back to the roles. So in a hypoglycemic crisis, if untreated, can produce unconsciousness and death. That's bad, right? Yes, it is. We can quickly reverse this by giving glucose. So if we identify it and they're conscious and looking at us, feed them. Give them your oral glucose if you have it, or a peanut butter and jelly sandwich works great with a glass of orange juice. But then they got to be monitored to keep it up that high. But if we can't, if they're unconscious or they're not able to safely swallow, or you don't trust them to safely swallow, do not put anything in their mouth. So the oral glucose doesn't come into play. You may need to get ALS there as soon as possible, or get that patient, if it's easier and quicker, get them to the hospital so they can be treated with an IV. And we're using D10 now. The hospital might use D50, all sorts of different things. So, but it's going to quickly reverse the glucose by giving them glucose. So, glucose monitoring devices, we already talked about a little bit about this. Agency specific, normal range 80 to 120. High is above 550. It will read high. And that is on most glucometers. There are a few glucometers that maybe give you higher readings at before it will say high. And then it will, I think 10, it would actually, I think the ones we have actually say low if it's lower than 10. If you have somebody lower than 10 and they're still alive, that's something you need to address right away, because the life is not going to be much longer left in there. If you have somebody in the 20s that's still talking to you, impressive. I've had a few of those. They're impressive. So feed them if they eat. Otherwise, we got to get an IV in them and give them some sugar, and that's where you got to get ALS there. Now, keep in mind, a lot of these patients, when they're still awake and they're confused, can be very combative. They could be uncooperative. You may literally have to wrestle them, and where we could get an IV in them to give them sugar, or we can give them an IM shot of glucagon. So, so protect yourselves, scene safety, make sure that you are thinking on your feet with your head on a swivel. Make sure, and when they are in this state, they don't know what they're doing. It's not their fault that they're being combative or they're not cooperating. It's not their fault. So calm, cool, collected, keep your wits about you, and do your job. Do what we got to do. All right. So what do we do when we assess? We're got history taken. We got to do that sample history. You got in your sample history, it's very important that we got to find out, did the patient actually, why are they in the state they're in? So have they taken their insulin, their pills, to lower that blood sugar? Did they do what they're supposed to do? Did they take their dose today, or did they miss it? Did they take too much of their dose accidentally? Did they miss a meal? Did they eat too much of a meal? Or are they currently experiencing, is there an illness? Do they have a UTI? Think along that line. So you got to be the detective, right? And if they're out hiking and it's a hot day, that kind of thing, yes, we might think, well, it might be dehydration, but always think sugar because they increased activity. Or if somebody's under you're studying for your exams, you've been up for 3 days drinking monster drinks, is it due to stress? Okay. If they have a history of diabetes, we got to determine, when did they last eat? What are the medications they take? Is it insulin, or is it oral form? And when did they take them last? And are they being treated for any other illnesses or medical problems? So do they have a history of stroke, high blood pressure, heart problems, COPD, whatever? And then we got to determine if the patient can swallow. So for us, on the BLS side of things, we're going to give oral glucose, right? So we're going to give this if all these conditions are met. Do they have a history of diabetes? We need altered mental status, but let's reverse that. If they are alert and able to swallow and follow commands, we can give it to them too. If they have an altered mental status, ixnay on the glucose, you can't do that because they could potentially aspirate. They're not going to understand enough to actually take it safely. So diabetes complications, you'll see a lot of diabetes patients. So this individual is probably type 2 diabetic, I would imagine. Later in life, he probably hasn't taken very good care of himself. As you see, it starts to run into a lot of vascular problems, peripheral vascular disease. You'll see a lot in diabetes, and that's caused by elevated levels of sugar in the circulation. Is just in the minute circulation isn't able to happen because of the consistency of the blood and all the sugar in it. So people need to take care of themselves. Neuropathic nerve pain. You might have nerve pain, or you might have decreased sensation in that area also. And because of lack of circulation, they don't have all of nutrients and ability to fight infection. So having infections is common. Very common to see diabetics with histories of stroke and history of heart disease. Keep in mind, when you talk to somebody that called, they might be having a heart attack or a myocardial infarction and not having chest pain because of that decreased sensation. So if they have decreased sensation, that's one of the things that can actually hide symptoms of heart disease, or it could have heart disease, but could be hiding symptoms of an MI because they don't have the sensation of it. So you got to look at the other thing. Okay, he's not having these, but he's weak, he's dizzy, he's diaphoretic, he gets short of breath. The list goes on. So if they're having those types of symptoms, it still could be a heart attack. Stroke, pretty straightforward in your face. Make sure you do a neurologic exam if it's appropriate for the complaint. And then retinopathy. This is damage to the small blood vessels in the retina, damaging the vision. So your statewide protocols. Now keep in mind, some of these protocols may be dependent on the agency that you're working on because your medical director will need to approve it. But history of diabetes is the history of diabetes that is controlled by medication. If you're approved in your agency, get a glucose. If the glucose is less than 60 and he's conscious and able to drink without assistance, provide oral glucose. Fruit juice, non-diet soda by mouth. Feed them. Feed them. I am a huge fan of, hey, are you hungry? Let's make you a peanut butter and jelly sandwich. I got sugar up before that. Give them some proteins and some fats. Keep that sugar up there. So that's where peanut butter comes in, and the carbohydrates of the bread and the jelly, and also in the sugar, in the peanut butter. We don't want to jack them too high too. So a glass of orange juice is good too, but a glass of milk is good too because of the fats and the proteins that are in there that will take longer to digest, stay in the system a little longer. So, all right. So that's your marching orders. Again, I invite you all the time to reach out to me if you guys have any questions. Go through your instructor. If they can't answer it, and hopefully I can. If I can't, I will find the answer for you. So thank you very much for your attention today, and see you on the next one.